To this now, the South African Medical Association is calling on government to do everything it can to speed up COVID-19 vaccinations. President Cyril Ramaphosa's government has come under heavy criticism for the slow pace of the inoculation drive. For more on this, I'm joined by the University of the Free State Chancellor, Professor Bonang Mohale, and Wits University's Professor Alex van der Heever. Good evening to both of you, and thank you so much for your time tonight. Now, Professor Mohale, let me begin with you. You've got some ideas of why South Africa, at least our response to having an actual rollout of the vaccine, has been so slow. Share some of those that you've penned.
Cathy, thank you very much for having me. I'm not the one who's saying we are slow. It is the president's own target that has not been met. Remember that the president set us a herd immunity target of 67%. That's 40 million South Africans, which means in January when it was announced, we ought to have been vaccinating 100,000 people per day. The Ministry of Health went on to say by the end of March, would have inoculated 1.2 million frontline healthcare workers. Now, by the end of March, we had only managed 250,000. We are now in April. We are told that the first vaccine we actually have bought that we will use the first dose to vaccinate, because up until now we've been using the Johnson's & Johnson's, where we are part of a trial in batches of 60 to 80,000. When we start in the middle of May, it means our run rate must be 250 to 300,000 a day. Had we started with 100,000 at the beginning of January, it meant we needed 400 days, which meant we had planned to finish in 2022, or 13.3 months, at a cost of 20 billion. Of course, the cost depends on the tag, the foreign exchange, the dosage, whether it's single or double dose, the cargo insurance, whether it's made locally or it is indeed imported. But also, if you think, Cathy, that only 16.4% of South Africans are on medical aid, that gives the medical schemes a maximum liability of 7 billion. To them, it's only 2% of all premiums. So when we planned, we were already 1.6 million doses behind. Where we are now, we have acquired on paper 31 million doses from J&J, 20 million doses from Pfizer, because that's only for 10 million people. But considering that now even some African countries are actually ahead of us in terms of vaccination. You see, the vaccination rollout was always going to be a race, because the country that will achieve herd immunity first will be the one that reaps the pent-up tourism demand. On the 27th of January, our BRIC counterparts, Brazil had already inoculated 579,000, Russia 800,000, India 2 million, China 15 million people. Where we are, we have always said, as I conclude, that this pandemic will always be about two things: saving lives and preservation of livelihoods. Where we are at the moment, it looks like the economic devastation will kill more people than the virus itself. In fact, a community that values more the loss of the economy than the loss of life actually doesn't need a vaccine. It is already sick. Thank you, Cathy.
Professor van der Heever, just to bring you in here, in terms of the role of leadership and how much of the situation that we're in today can be characterized as leadership failure versus just some of the structural issues that we've been told about when it comes to acquiring vaccines, your own views?
I think that despite the fact that there are potential structural barriers that everybody understood would occur, at the beginning of 2021, it's quite clear that South Africa failed to prepare its vaccine program during 2020. So even the rollout plan wasn't prepared. So it was also very clear that we would have not been able to rely on COVAX as an arrangement. So these global arrangements are only being set up for the first time, and they're only being tried and tested now. So they were also likely to end up being back of the queue for accessing vaccines in any case, because in most cases, bilateral agreements would begin to tie up a lot of the supply early on. So this was always going to be the risk, and this was what South Africa needed to prepare for. And those countries that actually anticipated this got their agreements in place quite early on. So it's quite clear that South Africa only began negotiating bilateral agreements very, very late in the day. And it's worthwhile noting that although we've managed to secure 31 million doses from Johnson & Johnson, in January, the Aspen Pharmacare was indicating that all 300 million doses it was going to produce this year were designated for export. And what that tells me, when you have that at the end of January, is that at that point, government had no contract, no negotiation, no agreement with Aspen Pharmacare and Johnson & Johnson for their domestic supply. That's how late we are in actually getting things done. So now, although we've potentially secured doses, our big problem is we don't really know when they're going to arrive and whether or not we've got the scale rollout capacity to actually administer at scale. Because, and I make this final point, in the case of the domestically supplied Johnson & Johnson vaccine, they've got the capacity to produce 1 million doses a day, according to them, according to Aspen. And basically, what we don't use in South Africa, they will export. So the slower we are, the less we will access from that production in 2021.
Professor Mohale spoke about, vaccines, the vaccination rollouts in different parts of the continent. And we know that in particular, the Sinopharm vaccine and Russia's Sputnik have been brought up as vaccines for discussion and debate in South Africa. Does it matter which vaccine people are getting at this point in the game? And I say this also being aware of the fact that we sold our AstraZeneca vaccines to the African Union. Professor Mohale?
In fact, what breaks my heart, Cathy, is the fact that today we speak about Aspen coming to our rescue. You and I will remember that this is the old Lennon's in Tebeja that used to be owned by the government. In fact, as we speak today, government co-owns a company called BioVac, a biopharmaceutical company based in Cape Town since 2003. So why are we in a spot of bother when we have the know-how, the technical competence, the expertise, the scientists can only be put down to the fact that there has been poor planning at the very best, excuse me. And then lastly, really what should concern all of us is the fact that, and Africa, it's not a poor continent, just poorly governed. The one thing that we have to fix is leadership or the lack thereof. Because great wars are won by good execution, not great plans. In this instance, there was no plan, therefore there couldn't be any execution. Because good execution will save even a mediocre plan. What South Africa has consistently been lacking for the last 27 years is a myriad of plans that have been developed, zero execution. The doing, the follow-up, the consequence management where things are not absolutely done. But also remember, at the time that our people were dying, some of the people who call themselves our leaders, especially in Gauteng, saw it fit to steal the money that was destined for PPE. In Gauteng alone, 2/3 of the money that was put aside for the procurement of PPE was used irregularly and indeed illegally. In simple English, it was stolen. So at the heart where children are dying, we steal from their mouths. At the time that the sick and the dying are desperately needing for governments guaranteed basic human rights of access to good health, of safety and security, and indeed education, we fail them once again. So I think, for me, that's really the concerning piece. When you look at South Africa, I mean, the top 10 economies in Africa, Nigeria is number 1 at $446 billion, followed by South Africa at 315, Egypt at 303. If you do the math, there is no reason why anybody in Africa, where we're talking about 1.3 billion people, 55 countries that speak 3,000 languages with a continental GDP of $2.6 trillion, and some of these countries with mineral resources that are either number 1 or number 2 needed by the world, where we are just simply failing to beneficiate. I think we need to go back to the drawing boards and say, what is it that we can do as the government, as business, as social partners, labor, and indeed civil society, using the NGOs and developmental institutions make it.
Professor van der Heever, perhaps your own views on the question I asked about, does it matter which vaccine we're using at this point?
I think that there are some vaccines which we probably shouldn't choose at this point, and those would be the vaccines where, for instance, we do not have proper data, so we cannot tell either efficacy or safety. But where we do have efficacy and safety data, we should be using those vaccines. The AstraZeneca vaccine wasn't shown to be effective against preventing infection for the South African variant. But it was still an open question and quite probable that it would have an impact on severe illness. And so would the Novavax vaccine as well. So it's odd that we basically chose not to even utilize our access through COVAX as well as through our own bilateral agreements, either of those vaccines. So I think it would have been appropriate to roll out with those because we had at least secured up to 3 million doses of AstraZeneca. And that would have got our rollout going. If we could still, and it would have been insane not to take advantage of the Aspen Pharmacare production in South Africa. And therefore, we should have used that vaccine for South Africa. We're best placed. It's a single-dose vaccine. It's shown to be efficacious. So I think that we should give priority to that. So I think that but I would certainly have rolled out with AstraZeneca. There's no reason for us not to have done so.
And Russia's Sputnik and Sinopharm?
I don't think that either of those have really been tested properly. So we don't really have enough evidence for either of those, either for the sort of the virus, the sort of the original wild-type virus, as well as the South African variant. So I think that I wouldn't, and the Sinopharm and Sinovac have been showing poor results, actually, quite recently. So I think that we would have good reason to be cautious. But whatever vaccine gets approved through SAHPRA in South Africa, we should be using. So the main question is not which vaccine do we choose, but whether or not SAHPRA has actually approved Sinopharm, Sinovac, or Sputnik V. That's basically where the key choice should be made about, decision should be made about whether or not we roll out, use them. But I think that the problem is that we've not made any of these decisions very rapidly.
All right. Let me thank you both for your time tonight. Professor Alex van der Heever, he's with Wits University, and the Vice Chancellor of the Free State University, Professor Bonang Mohale.